Good afternoon and welcome to the Alzheimer's Association's special program today, The Fundamental Role of Resources in the Pursuit of Health Equity for Dementia with Dr. Carl Hill in recognition and celebration of Black History Month. We're very excited to welcome our speaker, Dr. Carl Hill, who will provide us with an hour of learning and discussion. This program will be recorded so that we can share this information with all community members. Your microphones and cameras are muted to minimize distractions during the program, and we ask that you remain muted. As you have questions throughout the course of the program, please use the chat box feature that can be found at the top right corner of our screen. I am Robin Cohn, Director of Programs and Services for the Greater New Jersey chapter of the Alzheimer's Association, and I will be your moderator today. We will be able to share your questions at the later part of our program today. As a reminder, this program does not provide CEUs, a certificate of attendance, nor a professional certificate. Before we begin our program today, we'd like to briefly share some of our local programs and virtual services that can be used during our pandemic and always, every day, because we want to make sure that our community knows that no one should face Alzheimer's alone. We're here every day to help you. We're available wherever and whenever you need reliable information, education, and support. Our 24/7 helpline, 800-272-3900, is available 365 days a year with bilingual staff and translation services for more than 200 languages. Through this free service, specialists and master's level clinicians offer respectful and confidential support and information to people living with Alzheimer's, our care partners, our families, and of course, our public. Live virtual education programs and support groups are available by phone and online for our families, our care partners, and our public, allowing all participants and attendees to interact with speakers and ask questions. You can find information online at alz.org and be connected with local resources, our support groups, and community programs on Community Resource Finder at alz.org/CRF. You can also join our free online community and share concerns, advice on an online respectful forum and confidential forum at alzconnected.org. I'd like to now introduce our Alzheimer's Association Regional Leader, Christina Francell, to welcome our community and introduce our speaker today. Christina.
Thank you so much, Robin. It is an absolute pleasure to be with all of you today. Welcome to all of you. We have almost 150 attendees with us today, and I do anticipate that number will tick up more, which really tells us just how important the topic is today that we'll be talking about. As we recognize Black History Month, the leaders across our region in Pennsylvania, New Jersey, and Delaware felt that it was important to bring understanding and awareness to the impacts of healthcare access and dementia on our communities of color, particularly those most affected by Alzheimer's and dementia, our Black and Hispanic populations. Today's presentation will focus on the diverse profiles of dementia, how the Alzheimer's Association is stimulating health disparities research, and perhaps most importantly, how the association aims to engage all of our communities in the pursuit of health equity. We appreciate that you're spending your Tuesday afternoon with us, like I said, to learn about this important topic, and I am absolutely privileged and honored to have the opportunity to introduce to you Dr. Carl Hill, who is our guest speaker for our special presentation today. Dr. Hill is the Chief Diversity, Equity, and Inclusion Officer for the Alzheimer's Association. In his role, Dr. Hill oversees strategic initiatives to strengthen the Alzheimer's outreach to all populations and to provide communities with resources and support to address the Alzheimer's crisis. As a result of his leadership, the association has broadened its reach to diverse communities, including such vitally important partnerships such as the African Methodist Episcopal Church. Prior to joining the association, Dr. Hill served as director of the Office of Special Populations at the National Institutes on Aging. Throughout his 6 years in that role, he led the development of the NIA Health Disparities Research Framework, which stimulates studies focused on health disparities related to aging. He also directed the NIA Butler Williams Scholars Program, which provides yearly training for early career investigators interested in aging research. And I know, Dr. Hill, that we have some of your friends here with us today from that program and beyond. So without further ado, please allow me to turn the virtual podium over to Dr. Hill.
Thank you so much, Christina. That's a very warm introduction. I'm really excited to be here. We've been talking about this event for the last month or so, so it is time, and thank you all for participating, for coming on and learning a bit more about Alzheimer's and the pursuit of health equity. Really, really looking forward to this opportunity. So thanks, Kristen and Robin and Cheryl and Clay, everyone in Region 13 for hosting, I think, this opportunity to discuss health equity throughout the entire region. So I will take a moment to just share my screen here. And I will do that. And there. Okay. Okay, and then I will see if I can minimize that just a bit. Okay, well, so I wanted to take some time to as Christina mentioned, to talk about the fundamental role, as I see it, of resources in the pursuit of health equity. Really, in terms of a landscape today, reminding you, I think, so many of us know the foundational information about Alzheimer's and dementia science, but we don't want to assume. So we'll go over it, just a level setting of Alzheimer's and other dementia. Talk about highlights in early detection and modifiable risk. Provide some background, I think, on what I think is priority health disparities and its determinants. And then, talk a bit about what we all can do. I think we all can play a role in the pursuit of health equity, and I'll define that a bit and maybe bring a call to action from our time here today. So does that work? I can't see you, but I'm hoping that you're nodding your head. So we'll try to cover those things within the 45 or 50 minutes that I'll talk here today. So I wanted to just reintroduce you to, I think, the wonderful work of the Alzheimer's Association. Christina mentioned I came from the National Institute on Aging, and as soon as I got here, I had seen this symbol for so many years in my previous work, and I didn't know what it meant. And so in working with a former colleague, Dr. Keith Fargo, he told me that, the one part of this represents rigorous science, of the Florence flask here of discovery, which is really exciting. And we have just the best research team scientists with the Alzheimer's Association, led by Dr. Maria Carrillo and Dr. Heather Snyder, and just your Percy Griffin, just a wonderful team that is really pushing the scientific agenda forward. But also the other part of that symbol speaks to translating findings, or being sure that the findings that reach a certain level of consensus improve and protect public health, or in this case, really the lives of people, our loved ones in communities that could benefit from that research. So it is that rigorous research that informs the health and well-being of people and communities. which is so important. And that really just gets me excited about the role of Chief Diversity, Equity, and Inclusion Officer with a tremendous organization like the Alzheimer's Association, which is global and working to advance care, support, and research across the world. And so much of that work around the work that the Alzheimer's Association does is in advocacy. And when we talk about resources, we understand that the advocacy work through the Alzheimer's Impact Movement, the advocacy arm of the association, has taken federal funding from $448 million in 2011 to $3.1 billion in 2021, right? And so when you work at the National Institute on Aging, where I came from, you understand firsthand how this dramatic increase in resources can benefit early career investigators. So those folks that we know that are finishing a PhD in neuroscience and they're trying to understand how best to start a career. Well, more resources means more training opportunities. The pay line is different. When I say pay line, the percentage of applications that are actually funded at a place like the National Institutes of Health. So when those resources improve, everything improves. Established investigators who may be in other areas of research, they kind of hear about some of the resources that the National Institute on Aging might have, and they decide, how does my work relate to Alzheimer's or another dementia, right? So this dramatic, increase in funding, I think, is so important, and it really puts these resources, again, resources squarely, I think, in the public's eye for what we can accomplish with this research, what the taxpayers' dollars can accomplish with this funding and this research, right? So think about resources from that perspective as I continue to move on. And then we see here that this increase in federal funding means that there have been the development of these Alzheimer's disease research centers, right? So think about going from $400 million to $3.1 billion. You're able to develop these centers all over the country that are housed in academic institutions, and these centers are designed to expand and kind of diversify research. So instead of focusing on only one part of Alzheimer's research, we're really hoping that this advocacy and these resources can get researchers thinking, early career and established researchers thinking about a broad range of topics as it relates to Alzheimer's and all other dementia. So this diversifies research and education opportunities all across the country with new populations and new approaches to research. So again, resources has taken this field from one of the kind of moderately funded areas of research in 2011 to a priority based on the resources that have been advocated for and generated and provided to researchers all around the country, all around the world for this type of rigorous research in Alzheimer's and all other dementia. And so just to make sure that we understand why this is so important, right? Because, with a dramatic increase of resources like we've seen, this must be a public health priority. And guess what? It is, and we know that it is. Alzheimer's disease is the 6th leading cause of death in the United States. More than 5 million Americans are living with Alzheimer's right now. 1 in 3 older adults dies with Alzheimer's or another dementia. In 2020, Alzheimer's and other dementias cost the nation $305 billion. And if we continue heading in the way that we're going without a treatment, by 2050, these costs could rise as high as $1.1 trillion. And salute to many of the caregivers that are part of this event today. 16 million Americans provide unpaid care for people with Alzheimer's or other dementia. So however you look at this, from an economic perspective, from the lives and well-being of our loved ones and communities, comparing this to other outcomes. Alzheimer's disease is a public health priority, and it deserves the resources that have been committed to its attention. And also, just to level set, let's talk a little bit about what it is, right? So Alzheimer's disease is characterized by abnormal proteins, amyloid plaques, and tau tangles, which lead to what we may call cell death in areas of the brain that retain and form memories, right? So there on the left is Dr. Alois Alzheimer's, and he is credited with discovering this devastating disease. In the middle there is Dr. Solomon Carter Fuller. This is Black History Month, so you always want to acknowledge the heroes, I think, in science as it pertains to diversity. And in Alzheimer's, we know that Dr. Solomon Carter Fuller worked with Dr. Alzheimer's to make this important discovery. So he's credited as being the first African-American psychiatrist, finished Boston University Medical School, I think in 1897. And because of the discrimination that was taking place in the United States, he couldn't really practice or conduct the research that he was interested in. So he was relegated to performing autopsies, but he got really good in conducting those autopsies. And Dr. Alzheimer's recruited him to his lab in Germany to help him understand, which was a compelling research question at that time, right? So was this memory loss, problems with cognition? Was it only because of growing older, because of old age? Or was it because of some biological changes in the brain? And they discovered those biological changes to be abnormal proteins. Again, amyloid plaques and tau tangles and key areas of the brain that influence memories, right? So important discovery that was really the product of a diverse collaboration with Dr. Solomon Carter Fuller and many other researchers to make this discovery of what we're talking about here today. Also level setting, dementia is a syndrome. It's a collection of symptoms related to cognitive decline, can include cognitive, behavioral, and psychological symptoms. As I mentioned, important discovery by Dr. Alzheimer's and Solomon Carter Fuller is due to biological changes in the brain, okay? Now, there are other types of dementia as well, right? So there is Lewy body dementia, is characterized by abnormal deposits of a protein called alpha-synuclein in areas of the brain that influence memory, sleep, movement, and behavior. Two types of Lewy body dementia: dementia with Lewy bodies and Parkinson's disease dementia, right? So it's Lewy body dementia, also frontotemporal dementia, was the accumulation of protein tau, right? So we mentioned before with Alzheimer's, amyloid and tau. With frontotemporal dementia is the accumulation of the protein tau and TDP43 in areas of the brain that influence memory. So language, emotion, and sometimes movement is influenced here, right? And then also there's vascular dementia. So when compared to Alzheimer's disease, which happens when the brain's nerve cells, right, break down, right? That's Alzheimer's. Vascular dementia happens when key parts of the brain don't get enough blood, right? Or the blood with the proper oxygen and nutrients that it needs to conduct in a way that where memory and other cognition is not affected, right? So when you think about this vascular dementia, really interesting as we get into disparities, because things like stroke, hypertension, diabetes, high cholesterol, all may impact the quality of that blood that flows to the brain over the life course. Really interesting when we start thinking about exposure over the life course in those populations that may be disproportionately affected. I'm getting ahead of myself, but I wanted you to just put a pin in that one in terms of vascular dementia. But the important takeaway from right now is that Alzheimer's is the most common cause, right? So when when we take the pop quiz a little later, remember, Alzheimer's is the most common cause. Also, a nod to the caregivers out there. Just want to make sure that I update you because you're doing the heroic work in this area. Still, there are no therapies that can cure Alzheimer's. There's a list of FDA-approved therapies that may help with agitation or sleep, or in some cases behavior. So, but there are no disease-modifying drugs at that time. So these on the left are available to temporarily improve symptoms, but it's important. The field has not forgotten about this important need. There are loved ones that are living with Alzheimer's or another dementia today, right now, and we have to continue this important research so that their well-being is being considered, and the work that caregivers are doing right now can be supported with important discovery and important treatments. Now, so I mentioned that there are no disease-modifying drugs, but right now, as we speak, there is a treatment, aducanumab, which has gone through clinical trial testing, phase 1, 2, and 3. And when we think about clinical trial testing, we know that clinical trials are really looking at safety, being sure that the drug or treatment is safe and that it's effective, right? So this particular treatment, aducanumab, is the first that has gone this far through phase 1, 2, 3 in over 10 years. And the FDA held a review of this treatment just a couple months ago, and they are deciding on next steps. And they actually extended the period of their decision-making process. So we'll hear something more in the coming months. But this is pretty exciting because again, the first treatment that has gone this far in over 10 years, and we at the Alzheimer's Association certainly advocate for its approval, because if it can help, if it can help anyone who's doing this heroic work of caregiving or suffering with Alzheimer's or another dementia, we would like for it to be made available to do so. So keep your ears peeled and eyes open for more information from the FDA about aducanumab, but of course we hope for a continued rigorous review of this particular treatment. But we can't wait, because we know that our loved ones are suffering with Alzheimer's or another dementia. So we've got to look at some other ways that we might understand risk reduction for Alzheimer's or another dementia, right? And so mild cognitive impairment, I'll call it MCI from this point. It causes a slight but noticeable and measurable decline in memory and thinking skills. So 15 to 20% of people aged 65 and older have mild cognitive impairment. Why is this important? Well, there is a continuum of cognitive impairment that leads to Alzheimer's or another dementia, right? So you go from cognitively unimpaired, you can see it here, to mild cognitive impairment, all the way to moderate dementia, and unfortunately to severe dementia. So MCI is a known risk factor for dementia. Everyone who experiences dementia passes through MCI. So what does that mean? If you can understand how to prevent or delay MCI, or the continuum of this cognitive impairment to dementia, you can prevent new cases of dementia, right? Really important to understand mild cognitive impairment and some of the ways that we may be able to slow down this continuum. Real interesting things, right? And so as we work to understand more about this process, there's a global race to uncover and develop blood-based biomarkers for Alzheimer's and other dementia, right? And so if we can understand how to slow down this continuum and then identify, right, biomarkers, right, that can tell us that there's neurodegeneration, right, or a sign of the development of Alzheimer's earlier in that process, right, we would have done a great service for protecting public health. So right now, this is not in your doctor's office tomorrow, but you know, the clinical trials are using this these blood-based biomarkers, blood tests right now. So research is validating this amyloid beta in blood by comparing what is the standard in the field, imaging. So this imaging and cognitive tests. So keep your ears peeled. This has been hot at the Alzheimer's Association International Conference for the last 2 years in terms of a blood test, right? A new biomarker for Alzheimer's disease. This could allow us, again, if there's a way to detect this earlier in the continuum, then there could be some very specific ways of reducing risk over the life course in this continuum. So real important. Now, there was also, in thinking about this continuum, is a look at modifiable risk factors, right? Modifiable risk factors, really interesting. So the Lancet International Commission on Dementia Prevalence, really important commission, a group of scientists that provide recommendations. In 2017, during the Alzheimer's Association International Conference that the association holds, stated that 35% of global dementia may be preventable. 35%. Right? So preventable is a strong word. That means that there's some things that people can do, or that health systems can provide, that can prevent 35% of global dementia. Really interesting. And so they identified 9 modifiable risk factors. Education to the age of 15, right? So you think of education and dementia, interesting. What is the relationship there? We'll talk a little bit about that. Hypertension, so remember I mentioned vascular dementia. Obesity, again, hearing loss, depression, diabetes, physical inactivity, smoking, and low social contact, right? So modifiable risk factors. So again, we begin to think about this continuum and what some of the factors that could play a role in this relationship between mild cognitive impairment and severe dementia, as shown in the slide below. So this field is beginning, as we hear and know that there are other drugs in the pipeline, like aducanumab and many others that are going through clinical trials testing. We're understanding more about this continuum between mild cognitive impairment and dementia, and identifying some of the key modifiable risk factors. And so all of this is leading us to a belief that a future Alzheimer's therapy will likely include both lifestyle interventions. So when I mentioned those modifiable risk factors, things like hypertension, obesity, physical inactivity, those are kind of linked to lifestyle, right? So it will combine both a lifestyle intervention and medicines, like the one that I mentioned with aducanumab and many others that are in the pipeline. So it's important that the resources, going all the way back to, from $440 million to $3.1 billion, right? From a federal research perspective, the resources have gotten us to a point where we better understand that this future will likely include both lifestyle interventions and medicines. Really important, I think, because the field has taken off and we're understanding more and more because of this increased opportunity, and the opportunities are really undergirded by the resources that are available. Now, let's pivot a little bit to disparities, right? So we know that Alzheimer's is a public health priority. 6th leading cause of death, over 5 million people with Alzheimer's or another dementia today. It cost in 2020, $305 billion, right? 16 million unpaid caregivers. This is a priority, public health priority for everyone, right? For everyone. Well, there's some populations that are disproportionately affected. That means they're more at risk, right? And so, for example, Black African Americans are 2 to 3 times more likely to develop the disease than white Americans. Hispanic or Latinos are almost 2 times more likely to develop disease more than white Americans. So an already public health priority, there's some groups in this country that are even more at risk, right? And so the research is pointing to a host of factors, some of which I've already mentioned, right? Education, that has come up a few times, Poverty, poverty is access to important resources. There's that word again. Stress may increase risk. So this is, I think, just a priority research area, a priority equity area, the disparities that exist in Alzheimer's and other dementia. Well, there was also some really interesting research that took place during the Alzheimer's Association International Conference. And let me step back. I tell you, I have to really give a nod to Dr. Maria Carrillo and the Med-Sci team there. Because of COVID, we were unable to meet in person, and usually, we were scheduled to meet in Amsterdam. So real excited to take an international trip to discuss science for 3 or 4 days. And because of COVID, we have all been adjusting and adapting to the new ways that we engage and work with one another. So real important. And we had over 30,000 people attend the virtual Alzheimer's Association International Conference, and that was because of the hard work there of Dr. Claire Sexton and Dr. Maria Carrillo. So kudos to the team. But when we think about disparities and we think about genetics, right, there was some interesting research that was presented virtually during that meeting. And so the ApoE4 gene is the strongest known predictor of Alzheimer's risk for white European descended population. So that the field knows that, right? And so according to this research that was reported there, this gene seems to be less accurate predictor for risk for some Hispanic or Latin American populations, right? And so this means that there could be some other factors, or it may not have the same risk for all racial and ethnic groups. It begins to have us think a little bit about the diverse, I think, perspectives that we must take, that we must pay attention to when we think about Alzheimer's and other dementia. And from a disparities perspective, it means it's priority that we take a look at some other factors that could be more important, or more, that could play a larger role in why we see these disparities for, in this case, Hispanic, Latinos, or Black African Americans. And we know that Alzheimer's and other dementia has a high impact on Hispanic Latinos. Hispanics are more likely to have cardiovascular disease and diabetes. I mentioned that for vascular dementia, which are associated with increased risk for dementia. Hispanic Latinos are typically diagnosed in the later stages of the disease. As a result, incur higher care costs. So there's different perspectives for different populations. And I think that's so critical and very important. So let's define health disparities research, why this is so important. This is the investigation of differences at a population level that could be associated with a broad, complex, and sometimes interrelated array of factors that occur at various levels in the way that we think about difference, right? So there's the environmental, sociocultural, behavioral, and biological factors, right? And so diagnosis, disease, progression, response to treatment, a number of outcomes could be affected by age, education, income, occupation, identity, stress, right? So when we think about the risk factors, there's also an opportunity to think about the resources, right? The resources that people have so they can live their best lives, their best well-being, or reduce their risk for health outcomes, poor health outcomes like Alzheimer's or another dementia. So in this case, resources means, what do people have? What kinds of resources can they use? Like, we'll get into this, but what do people have to delay or prevent poor health outcomes? Really interesting to think about, right? So when you think about population level differences, right? Go back to your social studies class in high school, right? And so we're thinking about why this enduring question that came up, at least in my social studies class, was, why do some groups live some ways and others live differently, right? And is it interrelated, right? It's a real interesting way of thinking. I think about populations and how people live together. So think about that social work class, and I remember Max Weber, right? And I think that this this social work really informs the way that we understand health disparities or population level differences. And right, so you know, Max Weber was a philosopher, and he contributed to this field that which eventually became sociology, right? But he's a philosopher that thought deeply about these issues, and he really, you know, placed the majority of these differences on a way of life, right? Common to whole groups of men, right? So way of life, lifestyle, you know, kind of values, traditions that whole groups of people kind of share, and they share those, and that means that they move in a certain direction or they benefit from those in certain ways. Others may not. So he put this on a lifestyle perspective. And again, you know, pointing at the Alzheimer's Association International Conference, when you think about lifestyle, think about body mass index. I've, you know, talked about modifiable risk factors as they relate to physical activity and inactivity and obesity. These are decisions that people make, their lifestyle, right? And there was some research presented during the AAIC 2020, which was held virtually, that showed that higher body mass index between the ages of 20 and 49 may be associated with higher late life dementia risk, right? So we do know what's good for the heart is good for the brain, right? We talked a little bit about vascular dementia, and we talked about the role of stroke, hypertension, diabetes, high cholesterol. So again, there are some decisions that people can make, right, with their lifestyle, right, that could be important for their late life dementia risk, and that was presented during the AAIC 2020. Also, there was just a landmark study that was reported in 2019 that demonstrated the reduction of new cases of cognitive impairment by getting blood pressure, systolic blood pressure to 120, right? So intensive treatment by seeing a doctor or recommending lifestyle changes. So this is a landmark study because the intervention here saw a reduction, a 19% reduction risk for mild cognitive impairment, and then a 17% reduced risk for dementia. So this begins to, you know, again, open the door. Think about Max Weber. You know, he said ways of life, lifestyle, things that people can do. What can you do? Well, we talked about the modifiable risk factors that the Lancet Commission pointed to: physical activity, smoking, right? Obesity, hypertension. So it begins to open this door of saying, okay, hey, lifestyle is very, very important. There are things that people can do to potentially reduce their risk. The Alzheimer's Association has taken all of this momentum to lead a study, to lead the U.S. Pointer trial, which is going to be so critical and so important. And this is the U.S. study to protect brain health through lifestyle intervention to reduce risk. And so this is a 2-year multi-center randomized clinical trial that will be a self-guided and structured lifestyle groups. And we are currently recruiting in 5 sites around the country with a goal of 2,000 participants, and using a community-based perspective. So I'll get into that a little bit about the need to diversify study participants, but really engaging, using a grassroots approach to be sure that we're including as many people as possible in this important trial. And so you say, what is the intervention here? Okay, well, the intervention is linked to those lifestyle factors, right? So being sure that the individuals in the structured intervention get a certain amount of physical activity. They adhere to a certain nutritional or diet that is high in kind of the fruits and vegetables, taking on a Mediterranean format, low in saturated fats and sugar. People are staying cognitively stimulated. So we mentioned education, that has come up a few times around, you know, being stimulated over the life course, and then receiving the proper support, health coaching support, right? So I think real important for understanding. This is going to be it continues to be really excited about the U.S. Pointer trial because it's going to give us more information about the centrality of lifestyle, right? And what is a recipe? What type of physical activity? What kind of nutrition? And how much stimulation? What what recipe of these particular health behaviors, if you will be really important for reducing risk for Alzheimer's. So more to come there. Why is this important? Because I think in any situation, I think everyone wants to know what you can do, right? There are things that you can do to reduce your risk of mild cognitive impairment and dementia, especially, and this has come up regarding cardiovascular disease risk factors. What's good for the heart is good for the brain. And this is an immediate opportunity with life-changing impact potential. So again, you're keeping your ears peeled and eyes open for what the FDA says about aducanumab, really important. US Pointer is another one of those studies that is going to give us so much information. And if you have an opportunity to participate, and if you're in one of those study sites, please do. Now, again, taking a step back and thinking about that social work class again, and thinking about why certain populations are different than others or have different experiences. There was Emil Durkheim, right? And so a little different to what Max Weber said. He put a lot of these differences on the condition of the social organism, right? So he said collective activity cannot be encouraged beyond the point set by the condition of the social organism, meaning there's a relational aspect here. We're all kind of relating in ways that have a certain determination of outcomes from a population-based perspective. So something about social factors was important here. And so there's been some work around the role of, in this case, education and the association between race, ethnicity, and cognitive impairment. So thinking about those disparities, why Hispanic or Latinos or Black African Americans are disproportionately affected, right? And so there's been a bunch of research around social factors like education. And the relationship here is the more education, the lower the risk for Alzheimer's or another dementia, right? So education is usually measured by years. So you're going beyond high school and into college, into graduate school. So more education should be protective, right? And that's what the research is showing us. If we look at here, some research by one of my colleagues, Dr. Al Hazuri, found that those with high SES, and SES is a composite measure of education, income, and occupation, right? So you put those kind of three together in a formula, and those that have the highest education or the highest income or the occupational status, they're in the high SES group, right? So we're really thinking about social class here, and those with the highest SES in this particular study were able to remain dementia-free the longest, right? So there's something about income, having the best education, right? Having access to important resources. There's that word again. So having access to these important resources is protective, right? And it's something about that could be important for reducing risk for Alzheimer's, or in this case, dementia. Really, really interesting when you think about it, right? So resources in this case is critical and important. Mapping back to AAIC 2020, when you think about vaccinations, I think about vaccinations from a perspective of resources, right? So vaccinations means that you probably have some health insurance, and if you get your vaccinations on time, you probably have high quality health insurance. So vaccinations could be seen as as a proxy for having access to the important resource of healthcare. And there was some research, back at AAIC 2020 that found that a single flu shot was associated with a 17% lower prevalence of Alzheimer's. Interesting. Or another study reported that for people between 65 and 75, a pneumonia vaccine reduced the risk of Alzheimer's by up to 40%. So that's more frequent flu and pneumonia vaccinations were associated with an even greater risk reduction. Now, early days for this research. We just don't know where things are just yet. This is very, these are associations that we have to understand the many other factors that could explain this relationship. But again, at its very onset, this shows that having access to important resources could have an influence for dementia risk over the life course. Really, really interesting. Now, I mentioned what the Lancet International Commission on Dementia Prevalence and Intervention and Care did in 2017, right? So they came and they came to AAIC and they gave us some modifiable risk factors that really open the way that we think about dementia risk. In 2020, they attended the conference virtually and added 3 additional modifiable risk factors: air pollution, traumatic brain injury, and excessive alcohol use. Well, excessive alcohol use maps right into what Max Weber said around lifestyle, right? People decide to abuse alcohol. That's their decision. That's a lifestyle. That's a way of life in the way Max Weber mentioned it. Traumatic brain injury, it could be seen as a health behavior. Also, people are in accidents. So that's another very important modifiable risk factor that the Lancet International Commission added. But also air pollution, right? So think about where people live. Think about where people grow up as children. And at least if you were like me, I didn't have a decision on where I would live growing up. That's where I landed. And so this pollution, this just living in a certain neighborhood could present some type of risk for Alzheimer's or another dementia. Really, really exciting, I think, in terms of expanding the number of determinants that are important. And we think about disparities and where African Americans and Latinos live. There's been research that shows that these populations are more likely to live in neighborhoods that endure the highest air pollution, right? So again, there's a social factors here that Durkheim mentioned for a number of outcomes, and these social factors could be playing a role for these disparities in Alzheimer's and other dementia. Now, it's Black History Month, and we can't talk about sociology without talking about Dr. W.E.B. Du Bois, who's the first African American to earn a PhD from Harvard University in sociology. And his work was around disparities. We didn't call it that at the time, but it was trying to understand some of the behaviors of African Americans at the time. And he says, well, the appearance of crime, that's what he was studying, among Southern Blacks is a symptom of wrong social conditions. So he was mapping back to Durkheim, right? He said, this is of a stress of life. So to be a poor man is hard, but to be poor in a land of dollars is the very bottom of hardships, right? And so stress, something about living in the American society, right? So the social factors, but also being African American in this case and living in the United States was something that he really honed in on. And so we've talked about cardiovascular outcomes, right? So when you look at heart disease death rates between 93 and 2001, now quick statistics refresher. When you say ratio, 1 is equal, right? And we talked about education, right? So here, years of education. So you would think when you're looking at education and comparing it to heart disease, the more education, and if we're looking at the black-white ratio, right? Again, ratio 1 is equal. So we look at the black-white ratio. As years of education increase, the black-white ratio should go closer to 1, right? Because more education means everyone's risk should decrease. Well, when we look at this data published by Jamal and colleagues for heart disease death rates, the black-white ratio increases for Black men and women. So as years of education increases, risk goes higher for Black men and women. Really, I think, really interesting stuff, because it points to what Dr. W.E.B. Du Bois mentioned around something about stress and living in the U.S. society that we've got to understand for a host. In his case, it was crime, but for a host of outcomes. And when we think about heart disease, we know, again, what's good for the heart is good for the brain, right? And what's at risk for the heart makes risk for Alzheimer's or another dementia higher later in life. So again, thinking a little bit about when we come to understand this recipe of lifestyle, physical activity, nutrition, cognitive stimulation, or health coaching or social support, that there is a context around how people can adopt and sustain a certain lifestyle or a certain set of health behaviors. There are a number of factors, and here, this is the NIA Health Disparities Research Framework. There are a number of factors at the environmental level. We mentioned education, income, occupation, but there's also access to healthcare, quality healthcare, residential segregation, or their cultural factors. There's a host of contextual things that really play into how people can adopt and adhere to a recipe of lifestyle factors. Really, really important. So, in essence, when we think about resources from this perspective, we're saying we know that there are disparities. We know African Americans and Latinos are disproportionately affected. We've got to understand how the environmental factors, where people live, air pollution, the Lancet Commission added, and at least that one, very straightforward environmental factor to their list of modifiable risk factors. How environmental factors and culture. I'm not discounting what Max Weber said, but how can we bring in cultural factors to how does all of that come together to influence people's behavior, so that we can understand lower risk for the amyloid, tau tangles, sometimes alpha-synuclein, but how can we understand how all of that comes together to influence the biological changes that Dr. Alzheimer's and Solomon Carter Fuller and a host of investigators that are well-funded with the resources that the NIA is making available, that the federal government is making available. How can all of that come together so that we can understand these disparities? So in essence, what resources are needed to reduce health disparities and dementia? What do people need to reduce their risk as we think critically about modifiable risk factors, health behaviors, and lifestyle? There's been some really good research. There is hope, is basically where I'm saying here. And a colleague of mine, Dr. Megan Zulsdorf, is taking on a project here because of this increase in funding at the federal level. She's supported to do a project called Stress and Resilience in Dementia, STRIDE, where she's taken a life course perspective to look at early life adversity or stress, in the way Dr. W.E.B. Du Bois mentioned, how that over the lifetime can influence brain health, Alzheimer's disease pathology, vascular pathology, neurodegeneration, and how some of the resources, in this case, she calls them social ties or spirituality, support linked to belonging to a church. So all of this, how can all of this come together to protect resources, to protect people's risk for Alzheimer's or the dementia, right? And again, she's one of those researchers who is taking advantage of the support that's available at the federal level. Now, in order to have rigorous health disparities research, we need more diversity in the field in general, right? And so sadly, I've mentioned that African Americans and Latinos are disproportionately affected, but represent less than 5% of participants in clinical trials, right? Really, really, I think an opportunity that we all can get on board with. African Americans are less likely to be recruited. So this calls, I think, for something that we all can do, right? And that is to become aware of clinical trials that are studying Alzheimer's or another dementia, and to sign up as healthy volunteers, or to be sure that if our family member or loved one can participate in a clinical trial, that we do the things to make that opportunity available for them. Because participating in a clinical trial, one, I think, gets you into under a doctor's care, which is so very important. But then there's a legacy part of this where, as I mentioned, these treatments are testing safety and efficacy, right? And so if African Americans and Native Americans and and LGBTQ populations, Latinos are not a part of this research, then we won't know if these treatments are safe or effective in the groups that have the highest risk. And I think we all can play a part in being sure that does not end up being the case. Why is this important? Again, as I mentioned, and we've seen in some other fields where some of the treatments that have been approved, by FDA are shown to be less effective in some of the populations that were not part of the clinical trial. So we have the opportunity right now, I think, to address some of this, and the association is taking part. And I'm really excited about what US Pointer is doing from a grassroots perspective. We have a couple of other studies where we're taking a community-based approach to be sure that we're working with organizations to learn how best to engage communities, to deal with this issue of trust. Trust is so very important, and to be able to communicate to potential participants that their participation will be safe, and to have them involved in this important area of research so that we can understand these disparities. What's needed for that kind of recruitment, I think, is resources. Again, some of the resources that we see at the federal level that are stimulating, much of the exciting research that I've described. Some of these resources, should be earmarked for understanding how best to recruit and retain underrepresented, disproportionately affected populations, right? It's going to take training and creativity, participatory engagement, working with community-based organizations, evaluating what works well and what may not have worked well, and reporting that at scientific conferences and in journals. There's a science around evaluation, and we want to make sure that those investigators that are set on understanding how to recruit and retain these participants, how can they share this information with one another? So very important. Again, less than 5% of the populations that are most at risk are part of these clinical trials. There's an urgent need to address some of that. And then there's a compliance accountability issue to be sure that we're holding, everyone to a certain compliance perspective when they take on a grant from a place like NIA or the Alzheimer's Association. What are you doing to make sure that we're including those populations that are disproportionately affected? Really important. A resource that the Alzheimer's Association has, Trial Match. This is like a dating, matching service, right? But you get an opportunity to participate in a trial. So Trial Match, alz.org/trial match means that everyone can go on. I encourage everyone, take a minute while you're listening to me, go on your phone and go to that website, because this is a great place to see all of the clinical studies that are taking place right now in Alzheimer's and other dementia. Again, very important that we get everyone who is eligible to consider joining a clinical trial. This provides a customized list of potential study matches to each user. So this is a resource. This is an example of, I think, a resource where if we're able to get the word out, right? And if you can serve as ambassadors, to the Alzheimer's Association and to all of its funded investigators, to get this word out about this resource so that people can become aware of the clinical studies that they may be eligible for, then I think we can make some impact on more inclusion and more diversity in Alzheimer's and other dementia science. So in summary, as I end up here, the Alzheimer's Association is a global leader for Alzheimer's and dementia science. There's an exciting time in research. New tools for detection and diagnosis are on the horizon. There's a growing diversity of therapies and tools under investigation. Remember, there's a combination of medicines and lifestyle. There's a need for resources and innovation for diverse participation. So critical and important. But as I've said a couple times throughout this presentation, new research leading to is pointing to a future of therapy that combines both medicine and modifiable risk factor interventions. Now, as I begin to close here, there is this dramatic, I think, increase in resources, again, from $448 million to $3.1 billion, right? So there's just this is a golden era, if you will, for Alzheimer's research. And if we develop a treatment by 2025 that delays the onset of Alzheimer's by just 5 years, 5.7 million people expected to develop Alzheimer's in 2050 would not. And so in this important time, and this has been called, again, the golden age of dementia science, it is absolutely critical that we use this dramatic increase in resources to understand the things that people need, the resources that they need, the people in all communities need to reduce their risk for Alzheimer's or another dementia. So, this could include, again, better education, access to any healthcare, access to quality healthcare, support, social support, when dealing with stress related to, for some populations, racial discrimination, right? So understanding the resources that people need, taking the resources that have been allocated to understand the resources that people need, all people, to delay or understand their risk for Alzheimer's or another dementia. Health equity is just that. It's achieved when every person has the opportunity to attain his or her full health potential. Health equity for our space means that everyone has an opportunity to take part in the clinical trials, and that the research is relevant and impactful for all communities and all people that could potentially be at risk for this devastating disease. There was some great discussion from Dr. Lisa Barnes during AAIC 2020, who really argued for a paradigm shift, a new way of looking at this, right? And that is that, while traditional risk factors, and I'm quoting her, studied in predominantly white samples, provide useful information for understanding disparities, we must incorporate the lived experiences of diverse participants. And they operate through this myriad of determinants and risk factors at an environmental level, what people live and the hardship that they endure, cultural factors, the ways that people adapt and are resilient, right? The ways that people respond to stress, historical processes, right? Or if we think about recruiting individuals in the clinical trials, we've got to understand what the Tuskegee syphilis study meant for people's decisions to not participate. But all of this has to come together for us to unpack the many factors that could be important for understanding these disparities or lack of, I think, diverse recruitment into these important research studies. So with that, I'll end, but my colleagues are available to talk about anything that I've mentioned at 800-272-3900 or at alz.org. Don't forget Trial Match, and I'm looking forward to answering some questions. Thank you.
Dr. Hill, thank you so very much for a very exciting presentation and a very powerful presentation. We have a number of questions in the chat, and I'll start with one from Mr. Roach. First, thank you, Dr. Hill, for your wonderful and thought-provoking questions and thoughts regarding research. I do want to ask, when you consider health disparities with Alzheimer's as well as dementia, are there any states that are specifically targeting those most impacted with public health and equity strategies? So this is a very interesting question for us as we look at servicing our community for improving health equity. Can you speak a little bit about best practices, some states that may be doing it very well? Thank you, Dr. Hill.
Oh, thank you, Robin. And I won't single out any particular state. I think that all of our chapters around the country are, doing what we can to create relationships. I think our best way is, engaging communities, engaging those community-based organizations that advocate for the well-being of diverse underrepresented populations, African Americans, Latinos, and partnering with them so that we can better share our wonderful resources that the association has around care and support, education and awareness. We have resources, so we want to engage with communities. So that's very important. And then making individuals in these communities aware, right? Number one, and to trust their participation in clinical trials, right? So that we can understand the course of Alzheimer's and other dementia in diverse populations. So all of this, I think, starts at the community level with, really being able to link our excellent chapter staff in states all around the country with affiliates or representatives from community-based organizations so that we can partner to be more inclusive and more diverse, Robin.
Thank you very much, Dr. Hill. And we have a question from one of our community partners. Participating in a clinical trial as an African American does not change their demographics, their education, and economic status. Therefore, if we know in advance demographics, economics, and education are key risk factors, how do we best explain the benefits to an African American to participate in a clinical trial?
Absolutely. I think there are different types of studies. I think it's a really good question. And so, there's clinical research, clinical trials that are, examining treatments or devices. If there is a medicine that's being considered, we want to be a part of that. I think that all populations should be a part of that trial, right? But there are also studies, as I mentioned, from Dr. Zulsdorf, where she's recruiting individuals to be a part of a study where they're going to assess resources. They're going to assess where people live, their socioeconomic position, all sorts of contextual and environmental factors. So there are a range of studies that are available for people to participate in, and rightfully so. The resources have been ramped up at the federal level at $3.1 billion. So, I think there are a host of opportunities for us to learn more. The myriad, again, the contextual factors that are at play here, but that does not mean that we should not ensure that all communities are represented in those clinical trials that are testing specific medicines. Because again, safety and efficacy, we want to make sure that the outcomes, the findings are relevant for people in all communities.
And certainly the Alzheimer's Association is very active with recruitment for clinical trials. So we thank you very much for discussing that during your presentation. There were a number of data points linking obesity, cardiometabolic disease, heart health, and Alzheimer's. One of our community members wants to hear a little bit more about that. And then Dr. Hill, as you're thinking and responding to that, another community member wanted a little bit more information on any evidence that may exist that chemotherapy may have influence on the onset of Alzheimer's and dementia.
Okay, yeah, I'll tackle the first one there. So remember, we defined vascular dementia. It's different than Alzheimer's. Alzheimer's happens when the brain's nerve cells break down. Vascular dementia happens when key parts of the brain don't get enough blood carrying the oxygen and nutrients that it needs, right? And so there's some vascular outcomes that can affect that process: stroke, hypertension, diabetes, high cholesterol, and those could all be influenced by obesity or lack of physical activity or poor diet, right? So that is, and there's mixed dementia where a person unfortunately may have Alzheimer's and vascular dementia, right? So again, that speaks to lifestyle, and then contextualizing lifestyle means that people should have the resources to adopt and sustain a certain set of health behaviors, suite of health behaviors, and that links to things like access to fresh fruits and vegetables, opportunities to participate in physical activity, or stress and coping. I mean, the ways in which people engage in certain health behaviors, must be addressed by understanding a stress coping perspective, right? So, I had that donut yesterday because I was a little stressed about my week, or I didn't get a chance to get into my physical activity because I worked late last week, and I missed it, right? So there's a context around all of this that I think is so very important. As far as chemotherapy, Robin, I'm kind of looking through the literature and trying to understand this relationship, and we just don't know fully just yet. It's an area of exploration that I'm keeping an eye on, and once we have some confirmed findings, we'll be sure to share with the field, Robin. And if there's any literature, I will share with you so that we can share with your colleague there.
Yes, thank you so very much, Dr. Hill. I also want to talk for a moment about the pandemic. As you know, we have all been having a very difficult time with addressing the needs of our community during COVID-19. As you know, the Alzheimer's Association has extended our programming and our care and support services to be able to service all of our community partners, our community members, and of course, our loved ones living with Alzheimer's and dementia. Do you have any other comments that you'd like to make regarding improving health equity for people living with Alzheimer's disease, certainly all dementia and care partners, especially during this time of COVID?
Yeah, I tell you, COVID-19 as most acute, kind of health risks has really exposed the importance of, what we might call the social determinants of health, linking that to, Emile Durkheim and W.E.B. Du Bois, the fact that access to important resources, again, plays an important role in those populations that are disproportionately affected. It just underscores, how, a lack of resources or, being socially isolated is an important determinant, or, how caregivers who are, considering risk and being sure to keep, distance from a social perspective, are unable to provide the type of quality care that they would to their loved ones who are dealing with Alzheimer's or another dementia. So, we're still unpacking what this means for Alzheimer's and other dementia. But I think from a disparities perspective, it again shows the importance of where you live, how you live, and how a thing like COVID-19 could impact a modifiable risk factor like depression or isolation. Just the pathway, the ways that this kind of operates through multiple levels of analyses to influence, who's most affected. And it's not surprising, and it's disappointing, but it's not surprising that the same populations that are most at risk for Alzheimer's or another dementia are most at risk for dying from COVID-19.
Well, Dr. Hill, you certainly provided a multifactorial approach to the research, the education, the programs and services that the Alzheimer's Association provides to our caregiver communities. And I'd like for you to this would be our last question for today. Do you want to talk about more multidisciplinary interventions? Is there any other point that you'd like to reference as we close out our program today?
Yeah, I'm excited, Robin, about, again, as I mentioned, the U.S. pointer trial, because I think we're beginning, to hone in on, those health behaviors or lifestyle factors. And those of us that are in disparities research, when we hear lifestyle, we know that, people make decisions every day based on a number of factors, and it's not all personality, it's not all kind of a individual level decision. There's a context around that. So this field is rapidly moving, I think, to an awareness of context. And the U.S. pointer trial is going to give us, more information. It's going to be a step in the right direction. And I'm really excited about how these early career investigators, these health disparities researchers, are going to utilize these resources that the federal government will be making available, that the Alzheimer's Association makes available, to undertake these health disparities research projects. There's a cadre of researchers that are just waiting to understand, how all of these factors impact lifestyle and ultimately could go on to impact risk for Alzheimer's or another dementia. So I'm very hopeful about what's coming down the pipeline for us to gain an even more understanding of the disparities in this field.
Thank you, Dr. Hill. The Alzheimer's Association wants to be even more helpful to ensure that people in our community receive information and services, specifically as it relates to diagnosis, the importance of early treatments, certainly the resources and the services that we have available for all of our communities to be able to take that next step and to be able to support their own loved ones, and they're certainly all of our community partners. How the Alzheimer's Association can be helpful? Well, certainly we have the opportunity to provide those services and programming, which we will certainly make sure that we communicate all of our services and our programming to our community members today. I do want to turn it over at this point in time to Clay Jacobs. Clay is our Executive Director for the Greater Philadelphia chapter, who will talk a little bit more about our information, education, and programming for our community members today. Thank you.
Thank you, Robin, and thanks again, Dr. Hill, for this important discussion. And good afternoon, everyone. As Robin mentioned, I have the privilege of serving as our Executive Director for the Greater PA chapter. And I hope today has provided an interesting and informative discussion for you. But please know that we are here for you all day, every day. Whether it's through our 24/7 helpline, which you've heard referenced, available in 200 languages and dialects, our support groups and educational programs, which are all currently available virtually, or a myriad of other resources available on a wide variety of topics. Use these resources and share them freely with others. We know that for each of you who were able to join us today, there are many others who couldn't make it and yet would benefit from the conversation and support. From my perspective, that's what today is, the start of a conversation, but it's only that. Alzheimer's disease and related dementias are uniquely personal and impact people in all communities throughout Pennsylvania, New Jersey, Delaware, and across the country. That also means the solutions to better support each other, to raise awareness and make a difference, are embedded in those same communities. That's the work we do, and we want you to be our full partners in that. Within the next day, we'll be sending each of you an email with a survey. Please take a few minutes to tell us what you thought about today's program and to request more information, but also please let us know what's important to you and how we might work together to make a difference for those impacted by dementia. We want that feedback. It guides our work. Coming together today is a beginning. Keeping together will be progress, but working together is the real success. And so with that, it's my pleasure to turn things over to my colleague, Cheryl Francell, to close today's program.
Thank you so much, Clay. Thank you, Dr. Hill, and to all of you who took the time to join us today. I'm Cheryl Francell. I serve as the Executive Director of the Greater New Jersey chapter. And I want you to know that as an association, we're truly committed to understanding the needs of the many diverse communities that we serve. Our goal is to be accessible to you, to provide support, resources, and most of all, to offer hope. We're excited to see your survey responses, to hear your thoughts, and learn how you wish to engage with us next. As you've learned, it's pretty easy to connect with us through our 800 helpline or through our website online. There are volunteer opportunities that may be right for you. And we thank you so much for the time that you've invested today. This concludes our program.